welcome.
So I wanted to give you a map of where we're going in the next space of time. I'm going to talk a little bit about who we are, HHS in the region, and the divisions that we've talked about. Gary's division, so-called ASPR, the Administration for Strategic Preparedness and Response, and our division, OASH, the Office of the Assistant Secretary for Health. So sort of position us to orient all of you. Then talk a little bit about what's new on the federal landscape to promote equity as a result of COVID. So what did we learn from COVID? Many of those pieces started before COVID, as Sally talked about, were part of planning and recognition over the last 2 decades about equity in all its forms, not only race and ethnicity, but lots of other inequities across the domains of social determinants. Who might our new partners be? Because the purpose here is not only to talk about what's new on the federal landscape, but also to talk about who partners might be. Some are old friends, some might be new or better recognized by the federal government than they've been in the past. Recognized by all of you, but not always by the feds. And then how have we been working on equity in New England? So the first 2 pieces are really going to be talking about the national landscape, and then we're going to bring it down to what our office and what our colleagues' offices in the HHS Region 1 family do to drive toward equity. So just to give you a sense, we are HHS OASH. That's the office I represent. It's the Office of the Assistant Secretary for Health. We are a staff or coordinating division of HHS. I'll explain what that means in a minute. And even below OASH, there is the Office of Regional Health Operations. That's where all of the regional offices sit. I'll show you a map in a minute. And the mission and goal of the Office of Regional Health Operations is to promote broadly public health and safety of the American people and the folks in the region with an overriding mission of equity. So here are the operating divisions of HHS. I know people don't always like to look at org charts, but just bear with me briefly. There are sort of 2 halves of HHS, the operating divisions and the staff divisions. The operating divisions are the name brands that we all know: CDC, NIH, Medicare and Medicaid sitting under CMS, HRSA, which funds the FQHCs across the nation and other health delivery networks, SAMHSA, which funds states to do substance abuse and mental health work. So those are our operating divisions. They're the big kahunas, well-funded with program authority across the HHS family. Here are the staff divisions, and those are the pieces of the Office of the Secretary, Javier Becerra, that work to convene and coordinate across the department. So you will see there the Office of the Assistant Secretary for Health, OASH, and the Office of Regional Health Operations is subordinate to that. Just as a note, you'll see opposite our office, the Office of the Assistant Secretary for Health, is the old version of Gary's office, the Office of the Assistant Secretary for Preparedness and Response, which has now been moved into the operating divisions. This is actually a little bit outdated. This just happened, a little bit of an outdated org chart. So ASPR now sits as an operating division. So we are led by Admiral Rachel Levine, came to the Biden administration from being the state health official in in Pennsylvania, not New Hampshire, thinking New England. And prior to that, Admiral Levine was a pediatrician with adolescent health and eating disorder expertise. And she is a 4-star admiral in the U.S. Public Health Service. So she runs the U.S. Public Health Service, which is one of 8 uniformed services in the United States. They are a cadre of 6,000 public health professionals who do day jobs across the federal government, everywhere from EPA, Bureau of Prisons, NIH. They sit in their normal day jobs, and then in emergencies and disasters can be deployed as a commissioned corps, usually under the guidance of ASPR, and in this case with COVID, FEMA. So Admiral Levine is also worth saying the most senior transgender federal official ever to be confirmed by the Senate, and she is our leader in Washington. I mentioned the regions. Gary and I represent the HHS New England Regional Office, and I'm just going to back up a minute. We are joined by all of these operating divisions. So there is an administrator for children, for the Administration for Children and Families. There's an FDA regional administrator. There's a HRSA regional administrator. Not every operating division is present in the region. NIH is not. NIH is located obviously in Bethesda and funds people across the country. But in general, Gary and I have a set of colleagues with whom we do this work. And those folks sit in 10 regional offices across the country. We are Region 1, the 6 New England states. We're really the most natural region with a long history going back hundreds of years of mutual aid, interdependence, people living in one state, working in another, getting their health care somewhere else, lots of cross-border activity. And that means a lot when we're talking about tackling public health issues. You can see in some cases, the federal government has simply drawn a box around some states in the country and named them a region. And in general, the role of the regional offices is to be a middle person, a broker, a negotiator between what's going on in Washington and what's going on in the states. Washington likes to think we carry the water for them. We like to think that it's a very bi-directional communication. We give them as much feedback as they hand us initiatives to highlight and amplify. We have a wonderful region with incredible public health professionals. And so they get a lot of the corrective ideas and creative innovations and new ways of thinking about their initiatives through us back up to Washington. And of course, also lots of direct communication from state and community partners. But we also like to amplify what New England's response is to these federal initiatives. You can see on the left, those are some of the priorities that the OASH regional offices have in the coming year. They'll look familiar to you, and I'm going to talk about some, but not all of them. And I should say that I'm happy after the talk to chat with others, to be in touch, especially for some of the topics that I'm not going to be able to talk about, like what we're doing on maternal health and what we're doing on climate change. So please, happy to chat anytime afterwards with anyone. So let me move on now. This is question 1. What is new on the federal landscape to promote equity as a result of COVID? And before I jump into these 3 pieces, better data, improving the connections between health and social service, and then what I'm hoping is going to take everybody by surprise and give you great optimism that it reflects what Sally was talking about at the end of her talk, the new federal plan for equitable long-term recovery and resilience. It's groundbreaking, it's transformative. I only hope it lives up to all of those descriptions. So let me just say, we define in the federal government equity and health equity in much the way that all of you do. Out of the executive order from President Biden, the term equity means consistent and systematic, fair, just, impartial treatment for all individuals, including individuals who belong to underserved communities that have been denied such treatment. That includes Black, Latino, Indigenous, Native American, Asian American, Pacific Islanders, other persons of color, members of religious minorities, LGBTQ plus persons, persons with disabilities, persons who live in rural areas, and anyone otherwise adversely affected by persistent poverty or inequality. And then health equity, HHS's definition is the attainment of the highest level of health for all people. Population level factors such as physical, built, social, and policy environments we recognize can have a greater impact on health outcomes than individual-led level factors. And Sally talked about that. I see that Bert posted something in the chat about that. Gary spoke to it as well. All right, let's talk about better data. This is one of the 3 prongs that's got not a new focus, but a renewed focus coming out of COVID. And that's our first box up there. Developing a robust evidence-based data infrastructure is really central to a strategy to work on social determinants of health, right? So we really first can't fix what we can't measure. So HHS is focused on consistent collection of high quality data on social determinants of health. And we'll talk a little bit more about how that's happening. Second, in the context of social determinants, we can't really unleash the true value of data that is not linkable across programs. So from HHS's perspective, it's not enough for the leader of an individual government program to know all about their enrollees. The data systems need to collect and share comprehensive standardized information on a participant's experience, social needs, and demographics as they interact with federal programs, right? If you're going to drive toward equity, you need to be able to see who it is you're serving, and you need to be able to connect across those silos. One of the challenges during COVID-19, we read about it, we heard about it, many of us who are practitioners experienced it, is missing and underreported race and ethnicity data coming out of our health insurance system. And so HHS has undertaken efforts to impute missing data with, complex statistical programs. But the bottom line is we're missing 20% of the racial and ethnic identifiers in the Medicaid beneficiaries, among Medicaid beneficiaries, 30% among marketplace enrollees. And then there's this significant misclassification of Medicare beneficiaries because of old Social Security categories that are way outdated. So there's a strong effort at HHS to work with CDC and others, other data gurus across the department on really trying to fill in that missing data. And that is really a partnership with states as well. And there are a couple of other efforts to enhance data, including community level data share, which is a very cool initiative I can talk after the fact about. I was unaware of it. Adding information or fields on food insecurity, housing, financial strain, and transportation to the data that is collected from the FQHCs across the country that HRSA funds. That's untapped information that HHS is now requiring those fields to be filled in by our FQHC partners. And then a lot of work on national health surveillance by the Office of the National Coordinator for Health IT. So that's sort of where we are writ large on data. We know that there are tremendous initiatives in each of the states in New England around the data gaps that became visible during COVID, but that sort of gives you a sense of where HHS is. Let's talk a little bit about improving health and social service connections. I think folks on the ground do this all the time, but because of the way Congress funds public health and healthcare delivery and social services, the way those appropriations are made and the way the divisions of HHS have grown up over time, there are pretty impermeable silos. So one of the things that HHS recognizes is that some individuals enter the public health or healthcare delivery system, become Medicaid or Medicare enrollees through a social service connection. And the other is that people become, is vice versa, that people get access to healthcare services because they're connected to a social service agency. And so this second prong of improving health and social service connections is really a strategy in which we are trying to make sure both opportunities are open, welcoming, and well-funded, that there is essentially no wrong door. And really, once people have health coverage, we often see that alternative payment models like the one Sally talked about can foster that linkage with social services. There are ways to refer patients to resources. There are all kinds of programs that have grown up. The Medical Legal Partnership is one of those. There are many, they go by many names. An expert panel that was recently convened by HHS to look at this, to look at improving health and social service connections, has really produced a really nice report that looks at how an alternative payment model can prioritize social determinants of health and result in sort of a robust set of benefits and services to an individual or a family. Here's an example of an innovative approach to integrating health and social services that just came down from CMS to Massachusetts. Massachusetts applied for a waiver, and in September 2022, CMS approved that waiver. And it gives Massachusetts expanded authority to provide 12 months of continuous coverage for Medicaid for those being released from correctional settings, 24 months of eligibility for those who have documented, who are unhoused. So that focuses on health. But Massachusetts is also going to be able to provide time-limited housing supports, clinical nutrition education, medically tailored food assistance. And those services will be provided to a range of at-risk populations, including people who are postpartum, for up to 12 months. So there you see that Medicaid is paying for limited but appropriate housing supports, clinical nutrition education that almost gets at the food as medicine movement, right? This notion that food should be prescribable. And that's part of a Medicaid waiver. So it isn't rocket science. There have been waivers like this before, but I just wanted to mention one that just happened in Massachusetts. So it's a New England family event, and it really is, you can see the granular connection of health and other kinds of benefits that we know really drive inequity. Finally, we get to the most exciting part of this slide, and I'm so excited. This is the Federal Plan for Equitable Long-Term Recovery and Resilience. It was announced on November 17th. So if you haven't heard about it, that's the reason. It's a historic plan. It didn't get a lot of press coverage in mid-November for a variety of reasons, but I'm going to share a few key slides. But that's just to whet your appetite. Really would love you to look at the plan. There are lots of resources for trying to understand it. It's a bit dense and it's certainly lengthy, but let me dive in. So there it is. Building lasting resilience nationwide, the Federal Plan for Equitable Long-Term Recovery and Resilience. And then you can see the tagline, all people and places thriving, no exceptions. It is an approach that calls for transformational change in how the federal government understands its reason for being, right? Okay, so this comes directly out of COVID. So let me just, give you the quick headlines. The plan intends to guide long-term investment, so 10 years and beyond, and it really provides a new organizing principle, which is to leverage what we call the vital conditions for health and well-being. There are 7 of them. We'll talk about them in a minute. The plan provides a path, a lengthy, well-described path in several hundred pages, for a whole of government approach to coordinate resources to maximize vital conditions and with a drive toward improved community and individual well-being. The government exists, the federal government exists to improve community and individual resilience and well-being. Not to do particular things in specific programs, I mean, that's part of it, but to have this goal. So you can see there, the way that that's going to be done in the plan is to align, government departments to map them against the vital conditions, figure out what pieces of the vital conditions they have, to foster a community-centered collaboration, to maximize our investments, and to achieve equity and eliminate disparities. Let me go to the next slide. So the best way to describe why this is a change is to look at what we usually do when we're in steady state or when something bad happens. So when something bad happens, you can see those are the urgent services right there that anybody would need in a crisis or a pandemic, right? So, and that's where you can see the majority of the federal government focuses when something bad happens. And so when those services are provided, the goal is to get to equitable recovery, right? Within about 2 years. So this is recovering from, a hurricane, recovering from other kinds of disasters and emergencies. But the vital conditions right here, these are the 7 that the plan focuses on, are really what we need to reach full potential and to be able to withstand shocks, whether they're individual and family shocks, the loss of a job, other kinds of changes, or they are shocks like COVID-19. So this is really where the plan recognizes that much more focus is needed. And this slide is really the most important piece. So if your vital conditions, those are the ones on the prior page, those are really the social determinants of health, but described as, in those 7 ways, if they are not fulfilled or they don't exist at baseline, then the demand for urgent services grows, right? So if they don't exist or they are disrupted, then your demand for urgent services, those are the immediate needs, grows. And here's the key: no amount of investment in urgent services will promote equitable well-being or increase the readiness of our communities to withstand shocks. And that's why both sides of this equation need to be paid attention to. But if we don't have our eye on the 10-year equitable resilience piece, we'll get stuck in this equitable recovery piece. So, and here's the philosophical shift for the federal government: a clear goalpost that talks about well-being as what we're driving toward, a shared framework that enables that kind of integration that we talked about across silos, and then a shift in how we talk about it. And then finally, I just wanted to list, these are the vital conditions, and I want to call them out. Belonging in civic muscle, that is really about collective efficacy, freedom from stigma and discrimination, civic agency at the community level, access to the thriving natural world, basic needs for health and safety, humane housing, meaningful work and wealth. That includes good paying, fulfilling jobs, really attacking this issue of a permanent underclass as being necessary to the economy of the United States. And that's an intentional decision that this plan calls out and says is not the way to proceed. Lifelong learning and reliable transportation. Civic muscle is in the center because in this federal approach, it's really the piece that all the other vital conditions attach to. Finally, the last slide on this, just so exciting that I want to give you one more slide. These are cross-cutting recommendations. So they sit around those 7 vital conditions as actions the federal government needs to take that transcend any particular vital condition and that leverage federal money and federal authority to, in specific ways, drive toward equity. So that is the long-term recovery and resilience plan. Happy to talk about it afterwards or at another time, but couldn't be more excited about it. And that, if we go back to our question 1, which is what's new on the federal landscape, better data is always exciting. Improving those health and social service connections is critical to achieving equity. But this federal plan, which literally was established in April 2020, a committee of 100 senior officials in the federal government sat down at the instruction of the White House because we could see where the pandemic was going. So this is driven precisely by the COVID pandemic. It comes directly out of it, and you can see that the lessons learned are driven by that. I want to say one more thing. There are lots of non-governmental plans that this was built from and off. I did not include those slides, but there are a variety of large nonprofit organizations that have worked in this space. And so, the idea is that they will continue to work and that there will be some coordination with this federal plan. This is not something that sprung out of the brains of those 100 federal employees, but really builds on lots of work that has been done in the nonprofit sector over the last 2 decades related to social determinants of health and the vital conditions for thriving and achieving well-being. But it is the first time that this has happened in the federal government. And I just wanted to go back right here. The plan is a starting point for federal agencies to better coordinate, align in pursuit of well-being. Here's the key. The plan goes beyond other existing federal efforts to address recovery and equity and is the sole long-term focused initiative. And that's why we need to keep our eye on it. It will transcend administration. Question 2, who are our new partners? The purpose of our talk is really to talk about what's new coming out of the federal government on equity and who are we going to be working with? Are they old friends? Are they new friends? So very quickly, this list is familiar to anyone who works in public health or social services. As Gary said earlier, sometimes the best partners to reach people about health-related challenges are our non-health partners. These are all folks that we've worked with, CHW's Peer Specialist, NAACP, Urban League, lots of churches and faith organizations, BIPOC organizations. The piece I want to call out here, the new piece in terms of federal recognition, not what all of you have done, over the last period of time. But in terms of federal acknowledgement, is individuals and families with lived experiences of all kinds. I want to spend just a couple minutes on how this is being prioritized by the administration in ways that are new and that drive toward equity. So, three pieces here. This is really about partnering with individuals and families who have lived experience. I wanted to let you know that under the Biden administration, in the last 18 months, HHS has established something called the Equity Technical Assistance Center. Not available to all of you. It's internal to HHS. It's designed to build HHS's capacity to set up and run programs, policies, research, analysis, funding that is more equitable. And the ETAC provides tools and learning sessions, webinars, and TA to specific offices at HHS. We've used it a little bit. It's terrific. The work is guided by a steering committee of HHS leaders and people with lived experience who've been hired and work as paid expert consultants. They are people who live with and use HHS programs. The ETAC has actually an entire set of resources about how to partner with people with lived experience. So how to equitably recruit individuals, engage them in a non-traumatic way, and pay appropriately for their time. And I just want to show you a screenshot of that, the first page of that training, which came out in the fall. Again, this center has only been around for just a year and a half. Equitably engaging people with lived experience. This is the introduction. This is internal to HHS. This is how to build the capacity inside HHS to partner better. And that's really our second question. Then I want to move to some, research that's coming out of one of our divisions at HHS. The Assistant Secretary for Planning and Evaluation in December 2021, that's the shop at HHS that does all of the thought work, came out with a report in December 2021, so just the end of last year, showing that constituent engagement improves programs and policies, brings satisfaction and dignity to the people who participate, leads to innovation, and here's the important part, creates and undergirds accountability. And that's really important when you're talking about partnering with people with lived experience. It's important in general, but look at all of the things that HHS is learning it gains when it partners outside the usual silos. Another recent ASPE study found that engaging with people with lived experience improves the outcomes of federal programs, provides improved knowledge and awareness among federal staff, which is important, and it increases self-efficacy and community connectedness for the individuals who are participating in HHS programs. Finally, and this was released on Wednesday, so I feel like I'm giving you some hot off the press initiatives and things to be hopeful about, is the initiative that the Administration for Children and Families, so that's one of our operating divisions. It may not itself be a name brand, but it runs all of the human services at HHS. The rest of HHS is really devoted to public health and healthcare delivery, both physical and mental health. ACF, the Administration for Children and Families, does all of the youth and family serving programs, everything from Head Start to cash subsidies to foster care and adoption, runaway and homeless youth. ACF is the human service component. The goal and the vision of this new initiative, ACF puts family at the center, is to embed lived experience in ACF's culture, policy, and practice, right? Never has a federal agency said this out loud and then done what's necessary to really execute. It follows on the executive order. This is Biden's executive order last December, the executive order on transforming federal customer service and service delivery to rebuild trust in government, right? Long title for an executive order. Often those executive orders sort of float in space, don't necessarily have any traction. Here is an example of ACF putting that kind of transforming customer experience into a plan that emphasizes equity, economic mobility, and service delivery with the family at the center of those programs. Okay, so those are some examples of where we're partnering, and this really prioritization of people with lived experience who use our programs and have the experiences that HHS is trying to address the challenges and to ameliorate disparities and inequities. What have we been doing in New England to work on these issues sort of during COVID and as COVID has become routine? So just to recalibrate, we've talked about what some of those equitable plans are, data, integrating social services and healthcare, and the new plan that's coming out. We've talked about partners, old and new. Again, when I say new, I don't mean that you all haven't been working with people who have lived experience, that people with lived experience aren't part of today's program in the audience. I just mean that the recognition by the feds is new and comes directly out of COVID. Finally, let's talk about what our office and our regional family is doing, not just OASH, not just ASPR, but the other folks who aren't here today, who Gary and I represent. So we're not going to talk about all of these, but we're going to talk about some of them. I don't have time to talk about all of them, and happy to talk to you about things like maternal health and climate change and health equity after the fact, just because we won't have a chance to cover them. So let's talk briefly about sort of COVID and our post-pandemic, not really post-pandemic, we don't like to say that, but our the activities we're doing as COVID becomes more routine. Gary mentioned exploring the FEMA funding for equity activities. We are going to continue to work on that to figure out whether it's possible to have FEMA fund non-health entities directly. And if it's not, is there a way to streamline those MOAs or contracts with health entities that will allow a faith organization to be directly funded? So that's the first piece. The second piece is long COVID. And, you know, that is becoming an equity issue. 3 weeks ago, actually OASH released a new report highlighting patients' experiences of long COVID. So this was a human-centered design report, 1,000 hours of interviews, workshops, and research with people suffering from long COVID. So it's a report that really puts patients at the center. It's hyperlinked there, and generates a series of creative commitments and ideas that HHS is going to execute on. Frankly, you know, this is a time bomb, a ticking time bomb. If we thought COVID was bad, and it was horrific and grotesque, the idea that long COVID is disproportionately affecting those very people who suffered disproportionately and died disproportionately during COVID, it's the same situation. So estimates vary, but the research says between 5 and 30% of people who have COVID will get long COVID symptoms. 1 million people across the nation are out of work at any given time due to a long COVID diagnosis. And I don't know what those numbers are in New England. We can certainly find them. And that represents $50 billion every year in lost salaries. So this becomes a disability equity issue. And it's really important. You should know that 2 centers in New England are doing really great long COVID work. One at Yale and one somewhere else. And so some of the innovation and fresh ideas about long COVID, both clinical treatment and other supports, are actually going to be coming out of New England. So that's exciting, but a real equity issue. Next, just want to talk a little bit about community health worker sustainability. We run the New England Community Health Worker Coalition, have worked for 20 years on everything from certification to reimbursement to research on the value of CHWs. We right now are working on a consistent branding template that all 6 New England states can use to orient payers and employers about the value of CHWs. One member of my team was chosen to co-lead at headquarters a new intergovernmental CHW working group. This is brand new. Her name, the member of my team, is Georgia Simpson. Many of you may know her. She's our health equity lead. And they're looking at novel reimbursement models and how other parts of the federal government pay and use CHWs or CHW-like professionals. And then really important, in 2023, we are going to look at how CHWs can be key to climate change and health equity, to that domain of work, particularly looking at mitigation of disasters and tracking health effects. CHWs were at the center of our work on asthma inequities in the early 2000s, and the role that CHWs played in bringing down pediatric asthma disparities across New England. So CHWs are right there in the center. We are also tackling harm reduction. Sally talked about the tremendous jump in substance use and in fatal overdoses. We were making so much progress across the region, and with the onset of the pandemic and the onset of a particular phenomenon, using alone. You can be awash in naloxone, but if somebody is using alone, they will not be saved because they cannot, inject naloxone into themselves. Now, there are some technologies and interesting innovations in that space for people who do use substances alone. But just wanted to say that the isolation and the despair of the pandemic resulted in tremendous bump across New England in not just overdoses, but fatal overdoses. So we have been leading since March a series of sequential senior leader meetings where we pull together the 6 public health leaders and the 6 substance use agency leaders, and they sit and share promising practices, tough challenges, talk about unique technology and what they're doing next to try to bring down the rates of fatal overdoses. That's a process. We're meeting next week for our 3rd meeting, and that produces collaborations and partnerships at the senior leadership level. 2 things we're going to tackle in 2023 on this issue, driving toward equity, are trying to understand more about harm reduction activities that don't work for Black and brown individuals who use substances, and how we need to expand the toolbox of what harm reduction looks like. Syringe services programs are not enough, and many of you are working way beyond that, but the federal government needs to catch up with that. And we are also watching the experiment in Rhode Island, one of our members of our New England family. Many of you know the first supervised use site in the nation, in the United States, will open in Rhode Island sometime in the next year. That is a location where individuals can use substances under medical supervision, and it will help to alleviate overdose and fatal overdose. It is only one of the tools in the toolbox. Rhode Island likes to say they don't want it to take up all the air in the room. There are many other harm reduction techniques, but this is a strategy used by many other countries. The federal government under President Biden has not opined that it's illegal or that they will stop it. The Attorney General in Rhode Island has been quoted as saying he's interested in seeing how it goes. I'm sorry, not the Attorney General, the U.S. Attorney representing the Department of Justice, the federal government. So holding back any judgment. There's a whole research apparatus attached to it. And so part of what we'll be looking at when we look at non-traditional HR is how that program rolls out. It will be a good promising practice, perhaps, for the other New England states. I know it's more or less tolerable, depending on which New England state you're looking at. We know from talking to our state health officials that in some states it's unlikely to happen, but Rhode Island passed legislation, funded it with federal money, and here we go. And then finally, opioid settlement funds. There are billions of dollars coming in for the various pots of opioid settlement money. We are going to pull together the committees in each state, the 6 committees that work to make a spend plan on that money, right? And to drive over a course of 15 years of expenditures. That's really the time scale of some of our states, to drive toward equity in understanding how that money can be put toward sensible and effective substance use prevention, treatment, recovery. So we're really excited about that. We're the only region that's doing that kind of coordination. And I should just say that because the drugs and guns trade really runs through the 6 jurisdictions on 95, the idea of coordinating those expenditures, of buying some services, of buying some staff, of buying what's necessary to address substance use, to do that in a cross-state way makes a lot of sense. Want to talk just for a minute. I know I'm probably really running late, but I just want to show you these 2 slides because this is something that means a lot to us. When we talk about income inequality and economic mobility, wanted to just mention from the federal family, the big push in New England in 2021 and 2022 the campaign for the child tax credit to enroll families that did not know they were eligible for child tax credit payments. I'm sure you saw the headlines across the country, the evaluation that was done by Kaiser, commissioned, I think, by the New York Times, that looked at how the child poverty rate dropped so rapidly after the 2021 child tax credit payments were made. That was true in New England. We had about 50,000 families that were eligible. I can't remember now how many were enrolled, but we did really well in 2021 and don't have the data for 2022, but can share it at some point. We leveraged every public health partner we had toward that piece. Again, this is an example of something that really isn't anything to do with healthcare, right? And this isn't rocket science. You all have been doing it, but it's important that the public health and healthcare delivery system be participating in things like a child tax credit anti-poverty campaign, right? Because that's a driver of all kinds of inequities down the road. So we were big participants led by our wonderful colleagues at ACF Region 1. They are a vibrant team. We love to partner with them. As I said, they are the human service, social service side of HHS. And then this is really important. This is going to be a focus for us. And this really gets at economic mobility, at well-being, which is one of the big goals of that wonderful, equitable, long-term recovery and resilience plan. Our colleagues at ACF, those same colleagues, have led for 5 years this initiative called the Whole Family Approach to Jobs. It focuses on integrating social services and healthcare, but with a couple of foci. Benefit cliffs, which are when any individual or family tries to become self-sufficient by gaining employment, they can lose housing, food, childcare, Medicaid, a host of other benefits. So trying to ensure that states understand how they can moderate or modulate those cliffs so that people aren't disincentivized from losing all of the benefits that allow them to survive, but can also improve their lives by retaining the benefits and gaining employment. So there are a number of pilots around New England that are very promising on that. To look at silo busting, which we talked about a little bit, a parent advisory council is at the center of Region 1's Whole Family Approach to Jobs. And then to partner with philanthropy to do some of that silo busting work where HHS can't get its money coordinated, can't braid and blend. Elaine Zimmerman and ACF have used philanthropies to do that work to fill those gaps. The Whole Family Approach to Jobs is really the most imaginative initiative that has come out of the New England HHS office. I don't feel competitive. I don't feel envious. As soon as we heard about it, we asked if we could participate, and our job is really to provide advice on integration with public health and healthcare delivery. And to do things like participate in the child tax credit campaign. In 2023, we are going to look at expanding this work. And this is part of that equitable long-term plan to take advantage of the fact that 4 Region 1 localities are involved in Mayors for a Guaranteed Income, right? So that's this graphic right here, the Mayors for a Guaranteed Income. All Americans deserve an income floor. Chelsea, Massachusetts, Providence, Rhode Island, Holyoke, Mass, and Cambridge, Mass. 3 of those are doing pilots offering modest monthly guaranteed income and accompanying research to show how effective it is at removing the deprivation and scarcity that force people into decisions that don't drive toward equity. The results are very promising, as they have been around the country. This is an action that's occurring everywhere, but we're really excited to have 4 sites. None of them appear to be in northern New England. It's possible I missed one, or that there's a different initiative beyond Mayors for a Guaranteed Income that northern New England cities are participating in, and would love to know about that. There's really nothing revolutionary about this. It's really what the child tax credit was trying to do, to give low-income families a chance to catch up, repair a car, take a course, all of the things that are gateway activities to economic mobility and self-sufficiency. Finally, the work that the Mayors for a Guaranteed Income is doing nicely dovetails with new work that was announced by the new leader of the Federal Reserve Bank. Oh, am I muted?
You're good now.
Okay. Sorry. This is the last piece. I know I'm probably over. So the Mayors for Guaranteed Income and the Whole Family Approach to Jobs all loop back to this new announcement by the Boston Fed The Boston Fed covers the 6 New England states. So it's our Federal Reserve. And our Federal Reserve has done amazing work on income and wealth disparities. They did a report 3 years ago on the Black wealth gap in Boston that was groundbreaking. And so we've just heard in April 2022 under a new leader that they are launching some really definitive dispositive research on what is driving income and wealth inequality in New England. And we just heard about some new research they've done, just to give you an example of something we'd like to pursue, that partners guaranteed income, modest guaranteed income, with the issuance of baby bonds when a baby is born, and that combination is especially effective at supporting improved employment and economic mobility. So we're really excited about the research that's coming out of the Fed, and we think they will be a very active partner for us. And then finally, we are doing some work because the new Office of Climate Change and Health Equity that exists, it's the first one at HHS ever, sits inside OASH, sits inside our division. And so we are going to be amplifying some of their work in 2023. We don't have anybody assigned to the region. This is a new space for us. We've worked on environmental justice for many years, particularly as it affects asthma inequities and other kinds of diseases that are driven by pollution and toxins. But climate change is a new space for us. We are focusing on severe heat and tree cover equity. Those are topics that could be talks on their own, but happy to talk to folks later about where we see the entry points on severe heat and what we're thinking about in terms of tree cover equity. So those are places, just going back to our third question, where we're doing work driven in large part by some of the activities coming out of COVID, not entirely, but with a renewed emphasis and a renewed priority on people with lived experience and a broad range of drivers of the social determinants of health to achieve equity broadly and health equity specifically.